My name is Dr. Misbah Manzoor, and I'm working as a registrar in Department of Cardiac Imaging at Peshawar Institute of Cardiology. Today, I'm going to present an interesting echo case. So I would like to start my case with a quote of Lau, who said, "It is hidden but always present." So this is the pictorial depiction of what my today's case is all about. So I would like you all to keep this picture in your mind while referring to my today's case. Starting with the case scenario, it is about a 37 years old male patient who was referred from Afghanistan to diagnostic department. He initially presented in the cardiac surgery clinic for an echocardiogram. He had complaints of tiredness and shortness of breath since last few months. Vitals were all stable with a BP of 110/70, a normal pulse. The only relevant physical finding he had was a pansystolic murmur that was audible at apex and another grade 3 continuous murmur at the left and right sternal borders that was radiating throughout the apex of the heart. His initially laboratory data was unremarkable for all the baseline investigations, including CBC, RFTs, LFTs, etc. The only significant thing that we had from the patient was his past medical history. He had a positive history of sustaining some chest injuries in the bomb blast few months back. Following that, he had a CT thorax done, followed by thoracotomy. The report of that CT showed right-sided pleural effusion with collapse and consolidation of the right lung. A note was made of a foreign body of metallic density and with star artifacts that was present anterior to the lower segment of the esophagus. However, the thoracotomy done and the OT notes that we gained, they showed no foreign body retrieval. However, the fluid that was collected in the thorax was drained. Following that, patient had few episodes of palpitations and shortness of breath that became severe in the previous 3 months. During this time period, he had multiple investigations done, including the TEEs and transthoracic echoes in various centers of Peshawar. And the only diagnosis he was marked with was a perforated anterior mitral leaflet with severe MR. For that, he was put on medication. Surgery was advised, but he was not improving. So these are the images of transthoracic echo that we initially did. As you can appreciate, the same findings, there is a severe MR secondary to perforated anterior mitral leaflet, and there was an additional finding of a ruptured sinus of the valsalva that is draining from the aorta into the RA. And there is something else that we can appreciate in this two-chamber view. So I would like to ask if anybody of you can point out an additional finding except for the MR and ruptured sinus of valsalva. Yes, there is something attached to the basal segment of the inferior LV wall. So this was a report of transthoracic echo as I shared, as I discussed previously, ruptured sinus of valsalva, perforated MR, rounded calcific mass that is attached at basal inferior segment. So in order to know the exact mechanism and intensity of MR and gather further details about other significant findings, we proceeded with a transesophageal echo. These are the images of transesophageal echo, clearly showing us a ruptured sinus of valsalva and a continuous flow coming from the aorta into the RA. These are the measurements of the sinus. The next view, you can see the same rounded calcific mass attached at the similar site as it was appreciated in transthoracic echo. These images are showing the severe eccentric posteriorly directed jet of MR secondary to the perforated AML, as we previously discovered in transthoracic echo. So, as the patient had undergone different CTs during this period of time, so we wanted to have some objective evidence with us in order to jump and do another CT thorax. So what we did was, this was a report of the TE. It was the same, almost same as transthoracic echo with no additional finding. So before jumping to another CT thorax, patient was taken to the cath lab and cine images were taken in order to confirm the diagnosis that we had in our mind. And these are the cine images of the patient when he was taken to the cath lab. You can see a little teeny monster sitting just along the inferior wall of the LV, moving well with each beat. So now we had an objective evidence to do another CT on the patient because he was fed up of doing multiple investigations in previous months. And the only question he had in his mind was, more than his symptoms, he was concerned about that I had got hit by a bullet that went in my body, but it was never discovered and it never came out. So where is it? So then we did the CT, thorax, CT, cardiac CT, and you can see where the culprit lies, sitting peacefully in the heart after causing all the destruction it had. So cardiac CT that we just did was scheduled next day, and it reported to have a metallic foreign body in the left ventricle, giving the streak artifact. Along with that, the other findings included enlarged left serratus anterior muscle with subcutaneous thickening, pleural thickening, and fibrosis in lingual area, which appears to be at site of metallic trajectory. So patient was referred back to the cardiac surgery team with a complete diagnosis that stated as ruptured sinus of Valsalva draining into the right atrium and a perforated AML resulting into the severe MR, secondary to a blast injury with a foreign body that is probably metallic remnant impacted in the left ventricle. And we were finally able to address the concern of the patient that where is the bullet. So I would like to conclude my presentation that while as an echocardiographer, while doing your examinations, you should never be so focused on what you are looking for that you overlook the thing you actually find. So till now, the patient was continuously monitored just about the severe MR. Nobody tried to find out the pathology, that why there was perforation of AML leading to a severe MR. And the other finding, the ruptured sinus of Valsalva was continuously being missed. And greater than all, the foreign body, that was the culprit, and the reason behind causing all the injury was also missed in various TEs that were done before. So with this, I would like to conclude my presentation. Thank you.
है
जी सर,
एग्जैक्टली लोकलाइज कर सकते हैं कि कहाँ पे है, लेकिन वो जो आर्टिफैक्ट जनरेट होता है उससे उसकी एनाटमी बहुत क्लियरली बात का डिफाइन नहीं होती. तो जो कन्वेंशनल मोडालिटीज है ना, लाइक सिंपल फ्लोरो समटाइम्स कैन गिव यू बेटर इमेजेस देन द सीटी इमेजेस. तो उन चीज़ों को की अपनी वैल्यू है, उनको भी उतना ही एंथुसियास्टिकली यूज़ करना चाहिए जितना सीटी को आप यूज़ करते हैं.
Exactly, sir. They were probably because of the MR, because that object was just lying like a calcified rounded mass attached to the left ventricle. So he was having no history of fever or something like that. So probably the MR and the ruptured sinus of Valsalva, they were causing the symptoms of the patient.
This was the right time to go for the repair of the Valsalva as well as MR.
We referred the patient back to the cardiac surgery and left the decision on them. However, they were not very much convinced for touching that foreign body, because they said that it seems quite embedded in the left ventricle.
So, Doctor, what would be different if you didn't find that thing in the management or in the outcome?
Sir, definitely the management of the patient would have been same, but as I've told you that not only the perforated AML, the ruptured sinus of Valsalva was missed. We we received almost 2 or 3 reports that TEs were done by different centers, and no one of them reported ruptured sinus of Valsalva. So except for this incidental finding, the extra thing that we diagnosed was that additional rupture, because repair of the rupture would have have a serious impact on the well-being of the patient on the later on.
CMR is
Yes, sir. Exactly, sir. So, yes, sir, that was the reason, that murmur was the reason that the patient was again referred to us for a transesophageal echo and transthoracic echo. That yes, sir, we did have a report of various transesophageal echoes. 2 or 3 of them were reported previously. Any other questions?
I think इसमें एक learning point जो है वो ये है कि जो transesophageal echo करते हैं, that should be comprehensive.
Yes, sir.
Should not miss, ruptured sinus of Valsalva. This is not for you, for the other center जिन्होंने मिस किया था उसको. So ideally speaking, और इस सब सोसाइटी का सब चीज़ों का पर्पस भी यही है कि हम चीज़ों को systematically and comprehensive way में करें.
Exactly.
And after doing the examination, clinical examination, if you are picking up a continuous murmur, then you would look for something, causing the continuous murmur.
Yes, sir. So actually, he was initially treated in the peripheries, as I've told you that he was from Afghanistan. So he was treated in the peripheries of Afghanistan somewhere. This was the first time he was presented to Peshawar, because he was not, and his 1T was only done in Peshawar, in one of the centers of Peshawar other than ours. So probably that was the reason that the finding was missed repeatedly.
Will you contraindicate MRI for any reason in this patient?
Yes, there was a metallic artifact, so we couldn't have gone for MRI then. Any other questions? Thank you so much.